Yeah. Good morning, everybody. First of all, let me thank the organizers of this grand round for inviting me and giving me this opportunity. As you all know, Dr. Anil Dicruz was supposed to moderate this session, and I'm a last-minute replacement for him. So at the last moment, I have made some slides, and yesterday evening I have put together a few slides to make this panel. So you must have come over here for some entertaining panel of Dr. Dicruz. So I hope I don't disappoint you. So however, we have I would request all the panelists, I think Dr. Ved, a medical oncologist, is already here, Dr. Kane, Dr. Kaustubh Patel, the second surgeon, Dr. Sharma, Ashwani Sharma, is he here? Dr. Sandeep Basu, he's not there because this is predominantly a surgical panel. I think we have only one surgeon on panel. Okay, great. So let me start. We, as a surgical oncologist or head neck surgeons, we commonly deal with thyroid cancers, and these are good cancers to treat because they have excellent survival, both local control as well as overall survival, upwards of 90%. And however, about 5 to 15% of these cancers in various series have shown different statistics, present in a locally advanced kind of a condition stage, and there the outcomes are different. They have a high morbidity, mortality, and the survival goes down. From 90% it comes down to around 50% depending upon which organ has been infiltrated. And various organs can get infiltrated. If there is an anterior extension, then usually it's not much of a problem. It can infiltrate strap muscles, infiltrate skin, subcutaneous tissue, and still the disease remains resectable. But the moment it infiltrates into there is a posterior infiltration or a lateral infiltration, then it's a problem. It can infiltrate into the recurrent laryngeal nerve, it can infiltrate into the trachea, esophagus, larynx, or more problematic is when it infiltrates into the neurovascular structure like the carotids, vagus, prevertebral fascia, or more, even so if it gets into the superior mediastinal vascular structures. Even if you go into the AJCC or UICC TNM classification, then it has been classified as a T4 disease, divided into T4A and T4B. T4A is basically a resectable kind of a T4 disease involving a recurrent laryngeal nerve, airway, or the esophagus infiltration, and T4B into a unresectable kind of a disease. Obviously, it is not classified as a resectable or unresectable, but basically it's a resectable or unresectable disease involving a large vessel infiltration or a prevertebral fascia infiltration. So let's start our panel. Conventionally, the patients of thyroid cancers present with only thyroid nodule or lymph node involvement. What is a different kind of a presentation of locally advanced thyroid cancers? Because these patients present to surgeons first, I would ask my surgeon colleague, Dr. Kaustubh Patel, what is a different presentation of locally advanced thyroid cancers?
Yes, so if the disease has gone posteriorly, as you rightly said, and involve the recurrent, they would present with hoarseness of voice or change on voice. But mind well, we have to be very careful. Even with a paralyzed cord, patient can have a normal voice, because this is a chronic, many a times chronic disease where the opposite cord compensates. So that this is not the only sign, and that is the reason why all the thyroid cancer or thyroid nodule patients needs to have their vocal cords movement examined in clinic. The second thing is a tracheal involvement, in which the patient can come with some kind of a cough and hemoptysis. And if the vagus is involved, of course, the same thing, the vocal cord paralysis. Many a times these patients comes up with a huge lump in the neck, but not necessarily.
Yes, so as Dr. Patel had said, that usually these are compared to our normal thyroid patients, these are usually little more elderly patients and can have various symptoms like hoarseness, dysphagia, stridor, hemoptysis. These symptoms can be there, but must understand only in about 50% of the patients these will have different kind of symptoms. Remaining 50% of the patients may not have any symptoms. These are absolutely asymptomatic patients, as said by Dr. Kaustuv Patel. These are absolutely asymptomatic patients. This is a very, very indolent kind of a disease. So let's and that's the reason why we should have a high degree of suspicion in these patients. Even a slightest suspicion of on some investigation or a laryngoscopy, we should investigate these patients further. So let's kind of discuss few cases. These are kind of a hypothetical cases which I have put in at the last moment. So this is first case. I would say this is a 46-year-old lady presenting with a thyroid nodule for 2 years. It is growing, and she has a history of change in voice. The voice has become hoarse. There is no other history of any dysphagia, dyspnea, hemoptysis or anything. And she underwent the FNAC, which showed malignant cells. It has been diagnosed as Bethesda 6. First, again, I'll start with the surgeon first, then we'll discuss with the pathologist and the radiologist about the rest of the investigations. Dr. Patel, what first, how will you start working up this patient? How will you investigate?
So definitely the clinical exam is paramount, and we must look at her vocal cords,
Yes.
as I said. In certain cases, a fiber optic endoscopy is also very advantageous.
Yes, so scopy will come later. Amongst investigations, perhaps what would you
Would like to get a minimum CT scan of neck and chest.
Yes, so a contrast enhanced CT scan of neck and the chest you will get. Dr. Ved, what do you kind of, what information would you give, will be able to give it on a contrast enhanced? Will your preferred investigation would be a CT scan or?
Oh yes, always in such a situation, definitely we will do a CT scan with contrast.
Yes.
For sure, it's an infrared mass. We want to look at the extension into the chest. So for all these reasons, the CT is the best investigation with contrast.
Okay. Dr. Basu, there used to be in a thyroid some kind of this thing. We are jumping our gun and going directly onto the treatment part of it, but always there used to be a kind of a discussion about that we should not be using a contrast in a patient of a thyroid malignancy. What is your take on that?
Absolutely, that's a history, and you must get a CT scan with contrast. If your nuclear physician tells you not to do it, I think you have to have one-on-one discussion, give them the evidence. There is ample of evidence now, and rather than changing from doing CT scan, I think you should change the nuclear physician.
Dr. Basu's opinion on this?
In a case of the setting that we are discussing for locally advanced thyroid cancer, certainly CT is very important.
Yes.
When it is a solitary nodule and you are wanting, when it is limited disease, obviously we do ultrasound and that is the primary. But in this kind of a case, when there is a tracheoesophageal groove and all, posterior structure involvement, CT is done. And just to tell that, most of those guidelines which were telling that after giving contrast, your radioiodine should be done at 2 months, has now gradually reduced, because, in India, we have not ever done that urinary iodine estimation. There were some studies in AIIMS, but now there are, if you see the papers that have come over the 2010 to 2000, say maybe 12, 14, they tell 1 month stoppage of after contrast, this water soluble contrast, is good enough to bring that urinary iodide concentration, which is of very, very importance to do an iodine scan, is good enough. So point again is, even after giving a contrast, if you give 4 to 5 weeks, is good enough to do an iodine scan after that. So that's the
Yes. So, cutting it short, there is no contraindication to do iodine contrast enhanced CT scan, because the information that it gives is of paramount importance, and we have a window of 4 to 6 weeks between surgery and radioiodine therapy, which is good enough for clearance of iodine. Is there any indication to do MRI in this situation, Dr. Vaid again?
Dr. Deshpande, exactly when this trend was there that we were not doing contrast enhanced study in earlier days, we did try MRI in these situations, because then we can use gadolinium.
Yeah.
Now, thing is that these kind of pictures you do not get in day-to-day practice. The patient.
No, so to be very frank, because I did it at the last moment, I
Yeah.
just took images from just
No,
representative
exactly.
images. So don't go by the images.
Yeah,
right?
no, Dr. Deshpande, what point I want to make is that the patient is breathless, the patient is moving, the infrahyoid neck is always a mobile structure, carotid pulsations, breathing artifacts. So we went through that whole rigmarole of doing MR for thyroid and came to the conclusion that let's just put an end to it. Even this esophageal infiltration and all, we are able to pick up with high resolution CT today. So I would still say that we go for CT and not MRI.
Yes. So the investigation of choice is a contrast enhanced CT scan, which has a very high sensitivity as well as specificity. The only place where perhaps MRI would have some advantage would be if you are suspecting a esophageal infiltration, which has been said, or a prevertebral fascia infiltration, where you may add a MR to CT scan, but otherwise CT remains a standard investigation. Would you do a PET CT scan in this particular situation? Dr. Kaustubh Patel again.
Yeah, so this is a little tricky question, but my treatment is probably not going to change. So that's the reason why I would be happy with these investigations.
Okay. So I have put some kind of, I have made a statement that it is not indicated in a standard resectable non-metastatic classical differentiated thyroid cancer with a low morbidity of resection. So if that is a kind of a situation, if I feel that on imaging this is a standard differentiated thyroid cancer, it is resectable, then I'm not going to do kind of a PET CT scan. Where will I do it? Where if a FNAC turns out to be something like a poorly differentiated carcinoma, or if I'm suspecting anaplastic or a medullary carcinoma thyroid, if I'm suspecting a bad histology like a insular tall cell columnar variant where there is a high chance of distant metastasis. Two more relative indications where I have put it is that it's a known metastatic disease which is there. Patient has kind of a pulmonary metastasis which are there. In a metastatic disease also you will do resection, but you want to know whether those metastases are picking up kind of a radioiodine or not. So if the metastases are picking up radioiodine, this is a situation we would we know that they are unlikely to have a radioiodine uptake. So what is the take, what I have indication which I have put it? Dr. Basu, what is your take kind of?
So, if I have to, I will take MTC separately and all the other malignancies in a separate way. So, the primary role of FDG PET-CT to give an idea of the biology of the disease. So, it's not a mandatory thing, but certainly we do see, though we had the thing of flip-flop phenomenon, that the lesions that show up iodine uptake will not show FDG and those who show FDG will not. It is not like mathematics.
It is not absolutely mathematical, but it may give us some kind
some
of an idea.
guidance. So
see, before going ahead with some extensive surgery on a locally extensive resection, we may have some idea whether the radioiodine is going to act or not. So this is again, that's the reason why I have put it as a relative indication kind of.
Yeah, so if I see there is high uptake of FDG, that does not preclude that iodine will not concentrate, but I know the biology of the disease will be more aggressive.
Yes.
I would like to treat them with higher dose at the outset, to give soon after the surgery. So that is one thing.
So Mandar,
second is from the MTC point, MTC, I think now we have much better, gallium
Yes,
DOTA
so
is there.
I was going to
don't
ask you
think
whether you will do a DOTA or a DOPA scan
for
rather
MTC.
than MTC, that's
yes.
what. So for a MTC, whether you will do a DOTA or a DOPA rather than doing a FDG PET.
So now there is a very clear cut thing. In MTC, if we have a thing called calcitonin doubling time, in a metastatic disease, if your calcitonin doubling time is short, that is calcitonin is rising fast, FDG becomes the choice. So you have to have an FDG parallel. But if it is the calcitonin doubling time is slow, then your DOTA or FDOPA, if you have. In Mumbai, we were not having that much FDOPA, Delhi were having, but we were doing DOTA, traditionally, for the calcitonin doubling time, which is slow. So that is the take on metastatic MTC.
Yeah, so Mandar, in this case, whatever you do, whatever scans you do, if you don't resect this patient is going to end up with a tracheostomy, which will be much morbid than a resectable tracheal involvement. The surgery for resectable tracheal involvement will not be as morbid as to have a disease in the neck and a tracheostomy and have the palliation.
Okay, so then coming to our next investigation, will you do, like you are basing your diagnosis on FNAC, which patient will you do a core biopsy? Just I want to take a opinion first from Dr. Kaustubh Patel again, and then from a pathologist, how will she help us and by doing a core biopsy?
So, if my cytopathologist is in doubt, then definitely would do a core needle biopsy. The second thing is, if probably I want to, looking at the patient and the disease, if I'm trying to find out a reason not to operate, that kind of a situation, I would go and get a true cut, be very sure that this is still a differentiated thyroid cancer, and go ahead with that surgery, which can be a morbid surgery.
Yes. Dr. Karne, what all information can you give us?
Biopsy has a limited role in thyroid cancer.
I think your this thing mic is off. I said.
It's not on. Core biopsy has a limited role in thyroid cancer, unlike all other sort of cancers, because majority are differentiated, we know. Except, of course, papillary thyroid carcinoma, you can easily pick up on core. So also you can pick up maybe on cytology, but when it is conventional, not follicular variant. But in a large group of follicular pattern lesion, core biopsy may not be useful, because there you don't, what differentiated from poly is the obvious invasion what you see. The morphological features like hyperchromasia and mitosis, you will not get in a small region, not also invasion. Immunohistochemistry also doesn't help much in a limited material to decide whether differentiated or poorly differentiated. So basically, when it is conventional papillary thyroid carcinoma, maybe tall cell variant, which is not follicular pattern, and medullary thyroid carcinoma, core biopsy will be useful, because medullary, even if it is difficult on H&E, you can certainly employ immunohistochemistry and hit the diagnosis, which is not possible for follicular pattern lesions. Anaplastic thyroid, easiest to diagnose, of course, and that can be diagnosed quite often clinically. So also we can suspect lymphoma. Now when you have a DD of anaplastic versus lymphoma, core biopsy will be best. You can easily distinguish the two. So there are definite areas where core biopsy, but not for the run-of-the-mill cases.
Yeah, so that's what I said, that perhaps in poorly differentiated cancers or multiple times, many times it happens that we keep on getting inadequate sample, we would get it before going ahead with, or as Dr. Pat said, that if it's our plan of action is it's an unresectable disease, we are planning for some non-surgical modality of treatment, then before embarking upon a non-surgical modality, we would definitely do a core biopsy in this particular patient. We said that we'll be doing scopies. What kind of scopies would you do in these patients? Again, these are all surgical issues, so all questions are going to Dr.
So we'll do a fiber optic nasolaryngottracheoscopy for these patients.
Okay.
And we would like to see specifically the subglottic area,
Okay.
as well as the upper trachea, where there can be a direct infiltration.
And if there is a suspected esophageal infiltration, perhaps you would get a esophagoscopy also if there is a suspected. Literature mentions about EBUS also. Does anybody have any experience about EBUS in this particular, because there is a lot of literature on EBUS in tracheal infiltration. Anybody in the crowd, does he have any experience in EBUS in thyroid cancers, this thing which is there? Because there is a lot of literature on EBUS. I don't think we have no experience about EBUS, but there is which is there. So that has also been mentioned. Any role of tumor markers in these particular patient? Any? Again, I would say other than any suspected medullary carcinoma, I don't think there is any role. Other than, again, we said that we'll get a PET to see the differentiation, perhaps in a differentiated thyroid cancer. If you want to take a call whether you want to dissect it or resect it or not, this is one of the indications. Perhaps we can say that these are differentiated kind of a thing.
So if FNAC is Bethesda 3 and 4 and then the clinical picture is not fitting in, I think Dr. Shubhda can elaborate on getting a calcitonin, serum calcitonin done, where there can be a possibility of medullary thyroid carcinoma which is being missed.
On FNAC, sometimes you can recognize MTC, and if you do cell block there and there only, you can do immunohistochemistry and easily separate. You have to use only 2-3 markers, thyroglobulin, calcitonin, and one maybe neuroendocrine marker, chromogranin. You can easily distinguish. At Tata Hospital, I used to destain the smears when cell block was not made, which was usually the case. So cellular FNAC was destained, and then immunocytochemistry was used, and a project was done, and we could differentiate papillary thyroid from medullary and also follicular from medullary. So immuno is very useful, whether you do it on cyto or on core biopsy. Core biopsy is preferred.
So we have investigated the patient. Again, as we all know that surgery is the primary modality, there is no doubt about it. Surgery with the R0 resection which is there. Any role of external beam radiotherapy? Dr. Manali, what is the role of external beam radiotherapy in these cancers kind of?
So here what is the final histology?
See again, because
So
I have
I
not
can
gone,
divide
just
into
take a
three
hypothetical this thing, that in which patients
Okay.
would you give external beam radiotherapy?
So for differentiated thyroid cancer, the treatment of choice is surgery followed by RAI.
Yeah.
Radiotherapy is generally not considered and it is not needed. The indications are very few. Like the different studies, like the National Cancer Database Study, SEER Database Study, and the studies from Princess Margaret. There are different studies actually, no prospective studies. One of the prospective study has been just completed from our institute. So it is, whatever has given is for the gross residual disease. And for elderly patients, the age cutoff criteria was 45 years because previously the staging criteria was cutoff as 45. So now we can consider maybe 55 years. But the study from the Princess Margaret also has shown that if age is more than 60 years, so in those cases, you can consider if there is a microscopic residual disease. For young patients, definitely not. But gross residual, yes, we will consider. For medullary thyroid cancer, it is actually very controversial because, see, in differentiated thyroid cancer, we have an option of RAI. In medullary thyroid cancer, we do not have. But still for younger patients and completely resected, we would not consider for any adjuvant radiotherapy. But for older patients and if there is a gross residual in those scenarios, we will consider. And actually there is systematic review which has shown that radiotherapy has actually reduced the risk of locoregional recurrence by 38%. And this is actually not true benefit. We really do not know because the majority of the patient who received external beam radiotherapy, they are basically at a higher stage of disease, mediastinal involvement, so it cannot represent the true benefit.
Okay. So
for
a certain group of patients, Dr. Basu, if you have to give radiotherapy and radioiodine therapy, how will you time it with the radiation oncologist? What will come first? Whether it is external beam radiotherapy, whether it will be radioiodine therapy, and will it depend upon the radioiodine uptake kind of this? How will you time it?
So there is no, kind of a clear-cut prospective study regarding that, but theoretically, as it looks like, before giving EBRTC, radioiodine is definitely one of the most effective targeted treatment if it shows concentration, nothing like radioiodine. So you would like to take the advantage of that. So obviously we would go, so I think the sequence, the way you have put is perfect. So surgery with an aim to R0 resection, followed by radioiodine, what we will do 3 weeks, or even recombinant TSH where we can do that. So RAI followed by EBRT for R plus resection, and also a few things that you told like poorly differentiated CS. So I am again talking in terms of, we are talking now locally advanced thyroid cancer. So high Sheen score and
plus what I have not forgot to mention is a TSH suppression also, which will be done in every patient kind.
Yes.
Okay. Just quickly, sir. Yes.
There the chances of radioiodine concentration is also poorer.
Yes.
So for that, there may be a role of doing EBRT in the DTCs also, the papillary variants,
Okay.
but because you're expecting lower iodine avidity afterwards.
Can I just add, I know it's ending, but I thought it's an important point. When the tumors contain BRAF, it is supposed to be radio refractory. So quite often to start with, tumor may respond to, and later on it becomes radio refractory. That may be the point of this, and that may be indication of tumor progression to poor differentiation. That's why Basu also referred. So poorly differentiated thyroid carcinoma, but it is very low incidence, 2%. But you must think tumor becomes radio refractory, and yeah.
So radio refractory carcinoma is a different distinct ball game altogether. We are talking about locally aggressive. That's a different thing altogether.
So
now let's take some specific issues which are surgically pertinent. One, if we are operating upon a patient and we find that there is a recurrent laryngeal nerve which is infiltrated. So let's quickly take these surgically important issues. Dr. Patel, I would kind of put forth 3 conditions to you, 3 patients. Consider that recurrent laryngeal nerve, you find that it is encased at the time of surgery. One patient is that this is a patient, nerve is encased and that vocal cord is paralyzed. Second patient, that nerve is encased and that vocal cord is functional. And third patient is there that vocal cord is paralyzed, the nerve is encased, but the opposite cord is paralyzed. This side is functional. Now how these 3 patients you will treat? 2 issues we want to consider. Number 1, will you resect the nerve? And number 2, will you reconstruct the nerve? Quickly we'll discuss. I think we have just 2 minutes left now kind of.
Yeah, so ipsilateral cord paratic or paralyzed.
Yeah.
So this is a well differentiated thyroid cancer.
Yes, all 3 are well differentiated thyroid.
And if it is a sluggish movement, I would definitely preserve the nerve.
For a matter of
If it is
unless
frankly
completely
paralyzed, if it is frankly paralyzed, then I don't think there is a point in keeping that
So
area.
you'll resect the nerve.
I'll resect the nerve.
Yes.
Bilateral quads mobile, absolutely no indication for removing that nerve.
Yes, so you'll preserve the nerve.
Because we have an excellent RAI backup which can take care of R1 resection. And if there is a contralateral cord paratic or paralyzed,
Yes.
I would definitely not go on that side first. I would resect the paralyzed cord disease, which is the major burden of the disease, will go on the side where there is encashment, but still the cord is active. I would try and preserve the nerve on that side.
Yes. And would you prefer to use intraoperative nerve monitoring in this particular patient?
Absolutely, yes.
So this is the indication where it has been found to use intraoperative nerve monitoring in this patient.
All the locally advanced thyroid cancer needs intraoperative nerve monitoring because they are the ones whom you will have surprises.
Yes. So plus it must, when you are preserving a nerve, you must understand that all the gross disease should be removed. Preserving a nerve doesn't mean that you are going to keep a gross disease on the nerve. And in all these patients, adjuvant therapy is indicated. So this is something, there are 2 studies which have, one Falk et al. Which have shown that preserving an involved nerve did not show any decrease in the survival. Another study by Nishida et al. Again showed that preserving a nerve did not show any decrease in the survival. There is a HNS consensus statement which have shown that all kind of a functional nerves should always be preserved. Second thing we kind of said that will you reconstruct the nerve?
Yes, so reconstructing the nerve may not start the cord function, but it will give a tone to the cord. So the opposite cord will get a better compensation. So it's always recommended, and I usually do ansa cervicalis swing to the recurrent nerve.
So this is a Japanese study which showed that even a paralyzed nerve should be reconstructed. The problem is that usually you don't get a segment of nerve which is involved. It is usually where it enters into the larynx, it's involved, and therefore you don't get a distal segment, and therefore it is not easy to kind of reconstruct a nerve. But if you get a segment, then you should resect it, reconstruct it at the time of surgery itself. And therefore again, HNS consensus statement says that you should always reconstruct a nerve. Coming quickly to the tracheal infiltration, if you find a tracheal infiltration, how will you manage it?
Yes, so there is a case for tracheal resection.
Okay.
And
so
at
will you
least,
always resect a trachea, or what are the different ways you will manage?
so that will depend on the involvement of trachea.
Yes.
And the Shin's classification,
Shin's
you will take care, and accordingly.
Sorry. So there is a Shin's classification has been put up, I think it's been, and which says that there are 4 levels of tracheal infiltration, and for Shin 1 and Shin 2 you can just do a shaving, which is shown to be as good as has as good a local control as a wedge resection or a circumferential resection. But if there is a more deeper infiltration, then Shin 3 or Shin 4, you need to do either a wedge resection or a circumferential resection. I would not go into the further cases of, there's a clear-cut, inoperable kind of a case with a carotid infiltration. I would just say, what will be the line of treatment? What is it? External
Yes, so if the segment is expendable, then we would do a graft and we will resect, because microscopic disease is the best disease to treat with radioactive iodine or an adjuvant treatment. Gross disease, it's extremely difficult.
If it is not surgically resectable, what are the treatment options? One by one, I would say radiation oncologist. Monali, what will?
Yeah, so it is again differentiated thyroid cancer.
Yes.
Okay. So if it is not resectable, gross disease obviously, and if it is a young patient, good performance status, then would consider for radical radiation.
Okay.
Up to a dose of 70 creatinine.
Any systemic therapy options?
Systemic therapy, sir, if patient is remaining asymptomatic and burden of the disease, like in this case, is low, then we will observe till the patient is not symptomatic or disease not progressing rapidly.
Okay. And if the disease is progressing, what will be the options like?
So then there are targeted TKIs are available, lenvatinib or sorafenib. These are the drugs which we will consider. It is shown as PFS advantage. Till now there is no OS advantage, but it has very high toxicity. So only when the patient is symptomatic or there is a rapid progression of disease, in that scenario only we can consider those systemic therapy.
Okay. These are perhaps patients you will consider little earlier, because already there is a airway compromise which is there. So perhaps you would not make the patient wait for the patient to become symptomatic.